Hello guys, this is Dr.aditi here, and today we'll be discussing a topic which is a very important topic as far as the NEET PG entrance exam are considered, as well as it is a very important topic which we encounter in everyday practice of medicine as well as radio diagnosis. Today we are going to talk about the neurocutaneous syndromes. What are neurocutaneous syndromes? Neurocutaneous syndromes are a group of disorders which basically affect the ectoderm and affecting the central nervous system, the skin, and the eyes. There are many and multiple thousands of neurocutaneous syndromes, but a few important ones are around 30, and today we are going to discuss only 5 of them. To name a few would be the starting from the most important ones. It would be neurofibromatosis 1, then it will be neurofibromatosis 2, then it will be tuberous sclerosis, then it will be Sturge-Weber syndrome and the von Hippel-Lindau syndrome. The less more important ones would be the Proteus syndrome, the ataxia telangiectasia, the incontinentia pigmenti, the Cowden syndrome, and the Gorlin-Goetz syndrome or the Faces syndrome. Clinically, the most importantly and the most commonly encountered are the top 5 ones. So we will go by discussing each of these topics in 5 headings. The first would be the genetic, second would be the common mnemonics which will help us recognize the features, and third would be the basic radiological findings because going specifically into radiology. So we will go on by starting with the first neurocutaneous syndrome, which is nothing, that is the neurofibromatosis 1. The neurofibromatosis 1 is also called as a von Reckinghaunsen disease. Going with the genetics, it is usually associated with the mutation in the 17q chromosome associated with the neurofibromin gene in the RAS MPK tumor suppression pathway. It is usually an autosomal dominant disorder. One of the most common mnemonic which is used to remember the features of neurofibromatosis 1 is cafe spot. What is cafe spot? C stands basically for, whereas the C stands for the cafe lot spots. There should be at least 6 cafe lot spots in a period of 1 year. A stands for the axillary or the inguinal freckling. F basically stands for multiple neurofibromas, plexiform type. E basically stands for eye features, that is the leash nodules or the iris hematoma. S stands for various skeletal deformities, for example the sphenoid wing dysplasia as well as skeletal bowing. And P stands for positive family history, whereas O and T stands for optic nerve glioma. Now we'll talk about the specific radiological features. I usually discuss the radiological features of various multisystem disorders starting from head to toe. So starting with the central nervous system manifestations, the most commonly encountered is sphenoid wing dysplasia as well as optic nerve glioma. The optic nerve glioma can be differentiated from the optic nerve meningioma is that the optic nerve glioma characteristically involves the entire optic nerve, whereas the optic nerve sheath meningioma characteristically gives the donut sign on MRI. The second most commonly CNS encountered finding would be the focal abnormal areas of signal intensity, also called as the phases, which are seen as hyperintensity on T2 and flare weighted images. Then the other findings would be the juvenile pilocytic astrocytoma and the brainstem glioma. Now going with the various skeletal findings, starting from the vertebra, there can be a posterior vertebral scalloping. In the ribs, there can be ribbon shaped ribs, as well as there can be various other features, for example thoracic meningocele, as well as skeletal bowing, limb hemihypertrophy, and last but not the least, but multiple non-ossifying fibromas. Remember one thing, that the only way to differentiate between neurofibromatosis 1 and 2 only by clinical findings would be that neurofibromatosis 1 presents at a much earlier age as compared to the neurofibromatosis 2. Now let us move on to the neurofibromatosis 2. The neurofibromatosis 2 is usually associated with a later age of incidence as compared to the neurofibromatosis 1. First of all, now we'll start with the genetic findings. The genetic findings in case of neurofibromatosis 2 would be mutation in the chromosome number 22q, which is usually associated with the Merlin gene, which also affects the tumor suppression process. And the only main finding which has to be remembered in case of neurofibromatosis 2 is commonly remembered by the mnemonic MES or MES, which is multiple and bilateral meningiomas, ependymomas, and schwannomas, or bilateral acoustic neuromas. One important thing to be remembered is that in the case of meningiomas and schwannomas in neurofibromatosis 2, they can affect the brain and the spinal cord, both of them. Whereas in the case of ependymomas, it usually only affects the spinal cord and it is usually of intraspinal and intramedullary type. Now, going on with the third neurocutaneous disorder, it would be tuberous sclerosis, commonly also known as the Bournville pringle disease. Going with the genetic predisposition, it is usually associated with the mutations in the gene located on chromosome number 9 and the 16. That is the 9q and the going with the clinical features. These children usually present with the typical history remembered by the commonly known as a triad known as epiloia, where epi stands for epilepsy, L stands for low IQ, and A stands for adenoma sebaceum. They are usually females. Going with the findings, again we'll start from head to toe. Starting with the head, the most commonly associated finding in the case of the tuberous sclerosis would be going with the CNS findings of the tuberous sclerosis, the most common would be the various cortical and subcortical tubules, followed by the subependymal hematomas, and followed by the most common SEGA, also known as the subependymal giant cell astrocytoma, which is usually associated with large chunky calcification. The only way to differentiate between the subependymal giant cell astrocytoma and a subependymal hematoma is their growth. The SEGAs are usually associated by a much and more rapid growth. Completing with the CNS, now we're going with the thoracic findings. The thoracic findings, the lungs, the most commonly associated finding is the LAM. LAM is also known as the lymphangioliomyomatosis. How to differentiate lymphangioliomyomatosis, which is a cystic disease, from the other common cystic disease of the lung on HRCT, that is the LCH. The only way to differentiate is by the morphology. The cysts in the case of LCH are small and sometimes big. They are bizarre shaped, they are coals. Whereas in the case of lymphangioliomyomatosis, the cysts are diffusely distributed throughout the lung with normal intervening lung space in between. Also, in the third finding in the case of tuberous sclerosis would be the various cardiac rhabdomyomas. Then fourthly, the most commonly associated finding, it would be bilateral renal angiomyolipomas, renal cyst, and also associated with the increased history of renal cell carcinoma. The other abdominal findings, which are quite non-specific, it would be multiple gastrointestinal lymphangioliomyomas, would be the multiple gastric lymphangioliomyomatosis. The other skeletal findings would be calvarial thickening and the bone hyperostosis. These patients are usually female who come with a history of the breathlessness, and on sonography they are usually associated with bilateral renal angiomyolipomas. Angiomyolipomas are basically tumors consisting of three elements as suggested in the name. Angio consists of the blood vessels, myo consists of the muscles, and lipoma, it means fat. Going with the third neurocutaneous syndrome, the fourth neurocutaneous syndrome, it would be the von Hippel-Lindau syndrome. The von Hippel-Lindau syndrome, first of all, is usually associated with genetic predisposition on gene 3p. Secondly, about the clinical features or the various features of von Hippel-Lindau syndrome is usually remembered by one of the most famous mnemonics, which is known as a HIPPEL, that is the HIPPEL, whereas the H basically stands for multiple cerebellar, retinal, and spinal hemangioblastomas. I stands for the increased risk of the RCCs, P stands for pheochromocytomas and paragangliomas of the adrenal. The other P basically stands for various pancreatic serous cyst adenocarcinomas, the pancreatic cyst, and the various pancreatic tumors or the PNET. E stands for eye lesions and the endolymphatic sac tumors, and L stands for liver, renal, and pancreatic cyst. So this Hippel mnemonic is quite useful in remembering the features of von Hippel-Lindau syndrome. Now we'll talk about the fifth and the last most commonly associated neurocutaneous syndrome, that is nothing but the Sturge-Weber syndrome. The Sturge-Weber syndrome is quite famously known for the presence of various hemangiomas and angiomas throughout the body, but it is associated most commonly with the choroidal angiomas. Going with the specific CT scan or the X-ray finding, it is usually associated with a large tram-type calcification seen on one or the second side of the skull. On the case of MRI, we can specifically see characteristic leptomeningeal or pial enhancement, which is usually occurred due to congestion of the internal cerebral vein. If we scan these children later on in their life, the affected cerebral hemisphere usually decreases in its volume. Now, going on discussing a few salient features of the other neurocutaneous syndromes, we will first of all start with the Gorlin-Goetz syndrome or the basal cell nevus syndrome. The Gorlin-Goetz syndrome or the basal cell nevus syndrome, we just need to remember the diagnostic criteria so that we can pick up the MCQ. The Gorlin-Goetz syndrome, it basically consists of the major criteria, for example, the multiple basal cell nevus or basal cell carcinoma, multiple odontogenic keratocysts in the mandible. These lesions characteristically grow in the anterior posterior diameter of the mandible and they are cystic lesions. The other salient features, it would be various palmar pits, calcification of the falx cerebri, Sprengel deformity, bifid ribs, and the positive family history. Now, going with the other less common neurocutaneous syndrome, it would be the Cowden syndrome. The Cowden syndrome is typically known by its presence of multiple mucocutaneous tricholemomas as well as the gastrointestinal polyps. And thirdly, it also involves the breast and the thyroid. The lesions in the breast basically are fibrocystic disease of the breast, whereas in the case of thyroid, the lesions are multinodular goiter and cystic disease of the thyroid. Similarly, it can also predispose to breast as well as the thyroid carcinoma. Although the syndromes like the Gardner syndrome and the Turcot syndrome do not come under the heading of neurocutaneous syndrome, it is important to know the features of these two syndromes because they are commonly asked in MCQ.